introduce our next lecturer. We have Nikola Brzanov. He is a surgeon and the president of the Young Doctors Club in Skopje, North Macedonia. So I will give him the floor and we'll be ready to go. All right, Nikola, stage is all yours.
Hi there. And at first, let me introduce myself. I'm Nikola Brzanov, and I'm lecturer. I'm lecturing this lecture as a part of Emergency Medicine Symposium organized by MEDIPATH International. And many thanks to Dr. Shelley Bakar for invitation and for all her patience in working with me for going through this lecturing for the symposium. So this section is going to be all about abdominal trauma and its initial management in emergency department. So what I'm going to do through this lecture is that first I would like to give you some challenge question. I know it's easy one, but it's a good for start. It's the first lecture of the day. So this is, yes, we can go on the next one. So this is challenge question one. A 42-year-old man is brought to emergency department after being thrown from a train during fulfillment. He is hypotensive, but he has no hemothorax, a normal mediastinum, and no pelvic fracture. Focused assessment of sonography in trauma scanning reveals hemperitoneum. Hemiperitoneum. Which of following is the most likely? Kidney, liver, spleen, pancreas, or diaphragm? I'll wait for the answers and I'll see the answers so we can have some clue about it.
All right, some people in the chat, just make sure you're going to the link itself so that you could answer. There we go, things are moving.
Oh, that's okay. Actually, I can see what I can see now. It's good for you, some depressing for me.
All right. So it looks like the top answer so far is letter C.
Yes, the top answer is look like it's spleen, which is actually the right answer. And what's good for you that you know the answer. What's not good for me is that you know the answer, and maybe I shouldn't take this lecture. You're already good enough. And I can see the dilemma of the participants was either it's a spleen or kidney, and that's really good because I don't know, the kidney is also in retroperitoneum, so. First we split, later we will see the other persons. Okay, then we can go to the next one. So this is my agenda for my lecturing today. So at first we'll start with introduction, then we'll speak about the mechanism of injury as a really important thing in our diagnosis. When you make diagnosis, to know the mechanism of injury is different mechanism. It presents different injuries. Then we'll speak about initial management of the abdominal trauma, about a little bit about algorithm of abdominal trauma management, and also about most common injuries and their treatment. So this is challenge question number 2. You can get the answer later. But for this question, I would like to cover the material, and later in the middle of the lecturing, we'll see the right answers. But now you can take the question. So the question is: patient has been admitted to emergency room after falling 2 stories from a roof, sustaining a pulmonary contusion and hemothorax. Initially treated with chest tube. At 24 hours after admissions, the trauma nurse noted bruising in the patient's flanks. So the findings should raise index of suspicion that the patient also have which of the following injuries that may have been originally missed. So A, liver ulceration, pancreatic injury, diaphragmatic tear, and rupture of the small bowel. So I would like students to take the answer also, participants to take the answers for the question. So later we can move on. Okay, I think Shelley, you put this
Yeah, I put the answers later on where you had the answers.
Okay, then we can go and do not so challenge question, but we can go. It's okay.
Sorry, I saw it under the answers part, so I put it on that one.
That's just okay. So the primary goal in the evaluation of abdominal trauma, which is really important, is to promptly recognize the that require surgical exploration. So in that case, we will not lose time in diagnostic procedures or some other procedures. So you should really recognize that condition. Also, what is really important to avoid critical error of delay operative intervention when it's needed. So we can move on. Now we'll speak a little bit, so let's just talk about a little bit about overlaying principle having to do with abdominal trauma. When look at about the penetrating trauma versus the blunt trauma. So incidence in a penetrating camera trauma, what's really most injured in penetrating trauma is small intestine, then it's going by colon and followed by liver. Incidence in the blunt trauma usually so you have the answer now if your question. The first thing is spleen, then another solid organ, liver, and the next by incidence there's small bowel. Actually 66% of abdominal trauma, the spleen is the only damaged intraperitoneal organ. We can move on then. So let's move to stub wound. Now, if we talk about the penetrating trauma for a moment, stub wounds are 3 times more likely than the gunshot wounds. When you actually look at the incidence, however, as you might expect it, a stub wound tends to be less lethal than a gunshot wound, with stub wounds to the upper quadrants are more likely to be injured because most of the people came up and undersaw the stub in this direction. So the upper quadrants are more likely to be affected, and because of the majority of assailants are right-handed, the left upper quadrant is the more likely to be affected. The external wound of a stub wound can be very misleading when the stub is done. If the patient or the assailant were to move the knife, so the blade may go up and go down, so it can make a significant underlying trauma, but can leave you with a really small surface wound. So the surface wound can really misleading you of type of underlying injuries in abdomen. At other times, the knife may go and just leave and make a really nasty injury, but it may push everything back and not the puncture it, so you can have a nasty external wound, but have very little internal trauma. So that's a long way of saying that external wounds associated with trauma can be very misleading, and you never know what's going on underneath. So it may not look as bad as it is, or it could be look very worse than it is. So you just don't know by looking at the wound alone, and that's why the CT scans are so important, and the exploration of the wound is also so important. So stub wounds, in fact, we can go to another slide, shall we? So stub wounds, in fact, if you see the statistic now on your screen, only two-thirds of the penetration, they penetrate the peritoneum, and 50 to 75 of the wounds of the penetration can cause the vascular or visceral injury. So even if the peritoneum is involved, as many as half of those patients, they may have no injury inside of the peritoneum itself. So if you can see, the stub wounds can be very misleading, but remember, they can be misleading either the way what may look like a trivial wound on the surface, or it could be really catastrophic underneath of the blade move. So let's move to the gunshot wounds. We can talk a little bit about the gunshot wounds. Gunshot wounds, on the other hand, they are almost always serious because of the speed they are usually going to penetrate, and they cause damage to multiple organs. So, for example, 85% of the gun wounds will penetrate the peritoneum, and 68 to 94% of these will result in significant abdominal trauma. So the gunshot wounds should always be treated as a really serious one, because the majority of them will at the end be the serious one. So penetrating trauma, which is the stub trauma and also gunshot trauma, and we have that on the next slide, is that I'd like to tell you some couple other notes about penetrating trauma. Because trauma below the nipple line should be worked up as at much of the abdominal penetration injuries. But remember, the diaphragm moves as high as the nipple during exhalation, and then as low as the lower rib cage during the inhalation. So you have a that chuck section of your chest between your nipple line and your rib at the bottom of your ribcage that can be abdomen at some times and chest on the other times. So the stub wounds or gunshot wounds that in that middle area should be worked up as sometimes as an abdominal and sometimes as a chest trauma, but in some cases for the both up. So that's really important not to fail. Now we can move on to talk about some of the blunt trauma. Yes, so blunt trauma. Let's talk at first about the seatbelt injuries, which of course would be involved in blunt trauma. Seatbelts, even when properly worn, can result they can result in some injuries from the shoulder restraints in its way, and it's going to come across the right side of the abdomen. So if the patient throwing forward and the high impact collision, the shoulder restrained, so can cut the right side of the abdomen, leading to liver trauma. Whereas the passengers, of course, the seatbelt goes the opposite way. It goes from the left side to the abdomen, so the spleen is more likely to be injured in the patient throwing forward into the shoulder restraint. So drivers tend to are more likely to have liver injury than passengers more likely to have splenic injuries. Another problem we can see with the seatbelt is improperly worn seatbelt. Well, some of people will take their shoulder restraint and put it behind them in comfort, then they can sit in comfort. And then of course, if they're involved in collision, they are going to accordion down themselves, and that can result in compressive injury of the lower abdomen. So the lap belt riders or the iliac crest, and digs into the abdomen, we can see significant increased intra-abdominal pressure. So we can see diaphragmatic tear, and we can see bowel injuries. We can see also for this type of misconduct of the rules of the seatbelts, we can see the fractures of the L1 or L3. So they are known as chance fractures, because the ligaments are being pulled and lower back as the patients come down on themselves. So the seatbelts also, we can move on the next slide. So this is one sign we see usually for improper use of seatbelt. So seatbelts, they can be recognized by this external trauma. We call it seatbelt sign. And when patient came into hospital and they have either redness early or after the trauma, or bruising later on the stage across the iliac crests, and that's when we see that sign, there is a really big chance of sustained intra-abdominal injury. In fact, if you look on the statistic, 1/3 of the people who have external trauma where the seatbelt sits on the lower abdomen, and 1/3 of the patient, they will have a small bowel injury on mesenteric tears. So also there is a big chance, as we talk about that chance fracture of the lumbar spine, usually L1 to L3. So now we can move on a little bit to now let's talk about the assessment of the patient with potential abdominal trauma and what can be injured. So during the abdominal trauma can be injured sweat organ. There is hollow visceral injuries, retroperitoneal injuries, and diaphragmatic injuries. Initial action, what can be they can be, for example, patient can be present in multiple ways. They can be brought in emergency department by emergency medical transport, and typically boarded and collared. And but some of the injuries will be brought by private vehicles. So here, plan of the action is always to put spine collar and to proceed to accordance with ATLS guidelines. Also, the next action would be yes, we can go there, because this is something really well known. It's about older trauma patients, but also abdominal trauma patients should be taken in this way. So at first we should check airway. For example, if the patient is speaking full sentences, and we can then move to breathing, and then we can see the circulation. It's really important to put too large intravenous line, because you never know when we need it in the management. Then it's really important to monitor the patient, to place oxygenation, also a factor there. And then you can start with primary survey by looking for disability and exposure and environmental control. So the next we can continue with primary survey. So if the primary survey, if it's intact, then we should go directly to resuscitation can begin. And always here we need to have some things who should be in the emergency department. So we can take X-ray, we can take EKG, we can take I almost mean EFAS exam if we need it, or in some past times some of our colleagues, they use it DPL. And besides sonography, always we should make, if we can, make a fast exam sonography. For example, we don't have in our emergency department in Macedonia that kind of investigation at the moment, because our emergency room, it's not allocated with other emergency departments. For example, we have different emergency departments, one for surgery, one for internal diseases, one for pediatric diseases, gynecology, another for cardiology. So we as a surgeon, we are not good educated about fast exam. So of course, that's really important. And one of the minuses of our emergency department in Skopje is that surgeons are not educated for making fast exam. Okay, so now we can go on we can speak about the second survey. So on the second survey, you should complete history and physical examination. And we never go to second survey when the primary survey is not checked. So you can take this ample history example when you speak about allergies, about medications they use. In that way, you know about medical history background of the patient. So also it's really important that their last meal and drink. So maybe the next operation is going on, the anesthesiologist is really important for them to know about it. And also to speak about the mechanism of injury or events surrounding the injury. So let's continue then. What is really important? The first thing you need to consider when you're doing abdominal assessment, this is abdominal assessment by the second survey, is whether other injuries may alter your abdominal assessment. If the patient has other distracting injury, like several limb trauma that causes the extreme pain, and they may not notice the less acute abdominal pain, even during assessment, because the more distracting injury, like for example, the mangled extremity, may hurt so much and so worse. So abdomen, much worse than the abdomen, and they may fail to recognize their abdominal pain. So consider in fact that with distracting injury, especially painful ones, the patient is less likely to have an abdominal assessment that reveals injury. Of course, if the patient has a spinal cord injury, especially with paralysis and loss of sensation of the abdominal wall, so the assessment may become very difficult, because they can feel the abdomen, and also if the patient is diabetic, they may have neuropathies, and then that can decrease the acuity of their pain. They have been also, it's really problem if they're under the drugs or alcohol, and we should always take care of this, to consider this distracting injury from the initial injury of abdomen. So we can move on then. So we have this assessment. On the assessment, if we see that there is distension of abdomen during assessment, then that distension can come in from various causes, can cause this distension. For example, pneumoperitoneum, and usually that can come because some of the organ, like stomach, is injured, or some of the bowels, and then maybe distension will become from gastric dilatation. Also, distension can happen from neuropathies, from diabetes, ileus like a condition, and also hemiperitoneum, especially if there is some injury of the solid organ, for example, of the liver or the spleen. So we have a lot of liters of blood there, so they will do distension of abdomen. We can move on. So you can see by inspections, inspection is really important part of the assessment of the abdomen. During the inspection, we can see some specific sign which can happen after the injuries. One of them is a cooling sign. It's a hematome around umbilicus, and that indicates retroperitoneal hemorrhage. But this sign can happen they're usually not coming in the moment of the injury or in the first assessment. There we can see them usually during after 12 hours, and this is great ulnar sign. You can see that's a bruising on both flanks. So I think that now we have a challenge question 2. We already, yes, it's here. We will talk about it. So a patient has been admitted to emergency room after falling 2 stories from a roof, sustaining a pulmonary contusion and hemothorax, which initially treated with a chest tube. At 24 hours after admission, the trauma nurse noted bruising in the patient flanks. So the findings should raise the index of suspicion that the patient may also have which of the following injuries that may have been originally missed: liver laceration, pancreatic injury, diaphragmatic tear, or rupture of the small bowel. So let's see now. Okay, so from the answer, yes, most of you already have pancreatic injury. That's the true answer. Yes, that's a true answer, because pancreas is retroperitoneal organ, and that's when you see bruising in the flanks, that's great ulnar sign. And usually it happens when there are injuries in retroperitoneum, and there should be also bleeding to happen the bruise. Usually it's happening few hours after the injury, not in the moment. So this is the most common signs. The most common signs we can see on the physical exam, by the inspection. We talked already about the great ulnar sign. We we see the picture from the Cullen sign. Also, there is a Kern sign. I mean, that's a shoulder pain while supinating the extremity, and it's causing by diaphragmatic irritation, usually happening after splenic injury, and if there is some free air in abdomen, or there is intra-abdominal bleeding. Also, here it's balance sign. It's the next one we'll talk about. That's happening when we make percussion of the left upper quadrant, and that's usually meaning splenic injury, especially blood accumulating in subcapsular or extracapsular spleen. And that's seatbelt sign we see on the picture before, so we can move on now. The next step in assessment we can do is auscultation. So auscultation, we are always looking for some decreased or absent bowel sounds, and usually we associate them with fluid or maybe blood irritating the peritoneum. But also we should consider ileus as another cause, for decreased bowel sounds. Also, spinal cord injury or peritonitis, they can slow the movement, and also there may be decreased or absent bowel sounds. We can move on. Palpation. Palpation is really important when we make assessment because in alert patient, we will see tenderness by palpation in 90% in intra-abdominal visceral injury. So pain can refer from one quadrant to another during the palpation. So it's really important to start the palpation as much distance from initial site of the pain, and assessing the area of the pain last. Rebound tenderness, which is we can feel on palpation. It's really it's caused by sudden movement of irritated peritoneal membranes and against the abdominal wall, and the most cause is presence of blood, presence of chemical peritonitis if we have perforation, also enzyme spillage if we have injury of the pancreas, and also bacterial contaminants if some of the small or colon bowel is perforated. We can move on. The percussion also is important because we can feel much better what's inside. It's some kind of handwork, and we can feel dullness from some solid organ, which means there is a free fluid in the peritoneum or some solid mass. If we feel hypersonance here or solid organ, that means that there is free area in abdomen, rupture of whole organ. And if there is some fixed area of dullness, that means that there is bleeding from that specific organ. And dullness that not change with the position, meaning that we should think about some retroperitoneal bleeding from the pancreas, kidney, or some big blood vessel there. Now we can talk about diagnosis and differential, and also investigation we do during abdominal assessment. So it's really important to make a radiograph investigation. A chest radiograph will help to us to see if there is injury of diaphragm. So if there is injury of diaphragm, we can see herniated abdominal content in thoracic cavity. Usually that's can be colon or the stomach. And also by the chest radiograph, we can see if there is some free air under the diaphragm, so we can know if there is some perforation of the organ. So also anterior posterior plane is really important. Why it's important? Because we will identify of the pelvis fractures. And pelvis fractures, they are coming sometimes with significant blood loss, and also they are associated with an intra-abdominal injury. So it's really important to do as a chest radiograph, also to do a pelvic radiograph. Then we can move on. We can move on the next step I talked about earlier. It's focus assessment with sonography for trauma. It's a fast examination. We call it fast because it should be made fast. And that's a widely accepted primary diagnostic study. Many clinically significant injury can be associated also with free intraperitoneal fluid. So the fast examination, it can reliably detect small amounts of free intraperitoneal fluid and can estimate the rate of hemorrhage through serial examination, and it can essentially replace diagnostic peritoneal lavage. It was done before. It's a more invasive diagnostic procedure, and as I know now in America, fast exam is part of primary or secondary survey. Depends. We can move on. So fast scan. It's really important. It's really important because can detect hemiperitoneum in as little as 100 milliliters of the blood. Also, when you make a fast scan, it's really important to make it on a few points, because one of the points it's really which is really important. It's what we can find. It's we should also scan the thorax so we can see if there is some pericardial fluid, hemithorax or pneumothorax. On the next slide, we can see the points where, yeah, here we can talk about the advantage and disadvantage of fast scan. Advantage is that it can be done in emergency department. It can be done really quickly. It's non-invasive instead of DPL, and it's repeatable if we are concerned about changes in some vital parameters of the patients. And what are the disadvantages? Is that it's operator dependent. Like in our emergency department, we need operator for the fast, and if there is a lot of blood, we cannot define which organ is actually assessed, and also we can see only blood and fluid. So we will need, in that case, if the patient is stable, we will need CT scan. So on the next slide, we have that. Yes, we have here usually which are the most common places where we can find blood. So hepatorenal recess or Morrison pouch, splenorenal recess. Also, it's really important to check the pelvis, I mean the pouch of Douglas or recessus rectovesicalis in the man, and also pericardium to see if there is some tamponade of the heart. So the scan is usually done in that order, as the hepatorenal recess is the first to fill with fluid in the supine position, and it's really most easily identified. And if the indication for the fast scanning is to identify cardiac tamponade, the first view should be the pericardial view. So it doesn't have to be in this way. Always you have to have as the patient is individually different from each other. We can move on. So what means positive fast scan? So you see sometimes on the papers fast scan positive. What means positive fast scan? Well, positive fast scan means that there is any free fluid on abdomen or in the pericardium, and usually visible free fluid in abdomen. That implies that actually maybe we can visually some small plush there, but when there is visuality, maybe that's a minimum volume of 500 milliliters of the fluid there. The finding of blood in the pericardium after the trauma is also the indication for emergency thoracotomy, either in the operation theater. However, if there is no time, if there is operation theater on another floor or in another hospital, there should be made thoracotomy in the emergency department on the place. So fast scanning requires training prior to use and on trauma centers patients, and I really hope that Dr. Shelly Bakar will invite her in Skopje, so maybe she will educate our department to be ready for fast scanning, and in that way we will give to patient really better chances for survive. So you can move on. Well, now we'll speak about city. Later, we'll speak about that dilemma if the patient to go directly to operational theater or to go to city scan. But if the patient is stable, let's say the patient is stable, another really important procedure is CT scan, because it's non-invasive, and that's a gold standard for diagnosis of abdominal injury. The major advantage is we get is that we get precise location of the injury and also grading of the injury. For example, grade of the injury is really important because if we go by Moore graduation of injury of solid organ, Moore 1 and Moore 5, they are treated differently. So by fast scan, we can see in the moment if there is bleeding, but it cannot make differential if the patient to go to operation theater or to stay in emergency department for stabilization. And by the CT scan, we get ideal position when we can see the grade of the injury of the solid organ or some other organ. So we can move on now. Here also we are talking about you can see some slide about how you contrast. Contrast is really important when it's coming to injury, and the contrast could be given by intravenous way, oral way, or rectal. So intravenous is using from a really small needle. It's going through the vein, and it's used to highlight blood vessels and to change the tissue structure of the various organs such as liver, kidney, or spleen. And blood vessels in the organ who are filled with contrast will show up like a white areas on the X-ray or CT images. And by the oral way, we usually give barium sulfate or gastrographene, and then contrast is traveling through the stomach to gastrointestinal tracts, and it's really visible on the, also like a white image on the CT. And then there is rectal contrast, and also barium and gastrographene is given that way, and it's outlining the large intestines or colon. We can move on now. I don't know about this light. It's a little bit blurry. If it's a little bit blurry, then you don't have some ophthalmologic problem. And you can see here is table 5.2. I don't know if you see the table 5.1 before. And if you don't see it, then you have ophthalmology problem. I'm joking. It's just take a little bit break. Actually, 40 minutes of talking. So here is some advantages and disadvantages of DPL, FAST, and CT scan. And let's not talk about DPL because it's something it's not widely used now. And we already talked about the fast scan, which is advantages and disadvantages. And also I would like to move on because some of the time I like to spend with talking later with you. So we can move on now. And so the patient, any patient with identifiable injuries on ultrasonography, CT scan should be admitted or transferred to hospital or a trauma center because we need further investigation, monitoring, and future care. So the patient with no injuries on a diagnostic evaluation and they have continued abdominal pain, they should be also admitted to the hospital because we should make a check of their parameters for the 24 hours for minimum. Maybe we will do another abdominal exams and another fast exam, CT scan. And patient with no injuries who have benign physical exam, they can safely discharge to home with good instruction of what to return for. Usually my patient with abdominal trauma, when I send them to home, I usually would like to see them again for 12 hours, or some of them if it's really minor, for 24 hours. So the treatment is some really specter I would like to talk about when I make a lecturing for abdominal surgery. That's my favorite. But instead of treatments, we have to also talk about the initial management assessment, because if no good assessment, the patient will not get treatment good later. So antibiotics should be always started in emergency department. Tetanus also should be updated. Blood transfusion if there is need. So, but we have to have in mind the principle of permissive hypotension. Simple grade injuries for spleen at first grade and second grade, and also liver ulceration, can often be managed with conservative management and bone transfusion. Usually, the most of the injuries of the spleen and the liver, they are grade 1 and grade 2, and not every injury of the spleen and liver should go directly to operation theater. Instead, they can stay only for conservative treatment. So intestinal and colonic injury, typically they require surgical intervention, because we have chemical peritonitis usually there. The abdomen is contaminated. So exploratory laparotomy is on the table, I think, in the same day, as soon as possible. Pelvic fractures with involved pelvic vessel injury. It's really important to try to make interventional radiology consultation, because we can do arterial embolization, and in that way the treatment can be as much conservative as can be. Traumatic aortic injuries, and that is a sign that we have to go to emergency surgical intervention. And traumatic arrest due to penetrating thoracoabdominal injuries can be managed with an emergency department thoracotomy. That's a thoracotomy in the place, and also emergent operative intervention. Massive transfusion protocol should be activated, and if there is no place for thoracotomia for blunt thoracoabdominal injuries. So we can move on. So this is something really important about operative management. If you can see the diagram on your right side, we're starting with ATLS protocol, and if the patient is hemodynamically stable, then we will see if the patient has peritonitis, evisceration of some organ, some blood, a lot of blood there, pneumoperitoneum, radiographic confirmation of a missile within the peritoneal cavity. Then, if the answer for this question is negative, we can make a CT scan. And if some of this answer is positive, we should directly go to operational intervention. Also, if the patient will go up, if the patient is not hemodynamically stable, then the patient should go directly to operative intervention. We can move on now. We can move on now on some really important, that means damage control surgery. Usually should be made also in emergency department. And that's a concept of tailoring the operation to match the patient's physiology and stage procedure to prevent physiological exhaustion of the patient or the body. Once the hemorrhage is controlled, the patient should be aggressively resuscitated, coagulopathy corrected. Also, we should take attention to fluid responsiveness of the patient, and the endpoints of resuscitation to ensure that patients are fully resuscitated and to reduce the incidence of severity of organ failure. We can move on as we are at the end. This is something about non-operative management. So, as I told you before, solid organ injuries frequently do not require operative intervention, but they must be admitted for observation. And what is indication for non-operative management is patients to be hemodynamically stable, to have stable hemoglobin level during the first 12 to 48 hours. Also, no need for 2 units of transfusion. And also it's really important patient to be younger than 55 years of age. And also the alert and the patient who are able to interact during the abdominal examination, we can take them with non-operative management path. And I think that maybe the post-operative monitoring. So the patient who went to operating theater later after the operation, we should also then monitoring for progressive anemia, because there may be some other injuries, or the first injury who is not very well take it on the room. Then we should monitor for hypotension, tachycardia, and also failure to correct the pace deficit despite the volume resuscitation. So now, because I want to give to you this PowerPoint presentation, this is something which we speak about. This is some steps which should be made during the assessment and initial management. There is another slide, also colorful. Yes. And you can see for the hemodynamically stable patient, blunt trauma patient with a positive FES examination, and full evaluation of CT scan may be the warrant before admission to the surgical service. Oh, we can move on. So this is the summary. So it's really important to identify abdominal trauma in emergency, even we have some distracting injuries of the patient. We have to learn the approaches to abdominal trauma in emergency department, and, which is important in primary survey, which is really important in the secondary survey. Then we also, which is really important, is to identify shock if there is one, especially hemorrhagic shock. And also we should know about the indication when we need the massive transfusion protocol. We didn't speak about it on this lecture because this is something I want to take about the initial management, and this is really important field also. And also it's really important how to proceed with the management proper for abdominal and trauma shock. What means that management proper, which is really dilemma of surgeons or emergency departments, emergency medicine specialists in emergency department, is patient should go to operation theater or should go to CT investigation, and that way to know as much as possible for injuries inside the abdomen. But now we will see the case report. I want to move for next 8 minutes. So yes, this is the case and discussion. Let's take a rest with some waters, and you can, I can take one water, you can read the case now. So we have here a 27-year-old man. And as you can see, some motorcycle accident. There was a brief loss of consciousness, and blood pressure 85, 55, heart rate of 125. Then we have oxygen saturation for 99% and Glasgow Coma Scale value of 14. He complained of abdominal, shoulder, neck pain, and denied alcohol drug use. You can move on now. Yes. So he was given a normal saline bolus and 100 micrograms of fentanyl intravenously by paramedics there. And in emergency department, his initial signs now normalized, and we have 110 at 70, heart rate of 90, respiration rate 24, and oxygen saturation is 99 again. So a second large bore peripheral was placed, helmet carefully removed by in line of C-spine immobilization, and his primary survey revealed diffuse abdominal tenderness. So his initial FAS exam was positive, and his X-ray and anteroposterior AP of pelvis were normal. We can move on now. So what are the area consideration? I don't know, Shelly. Maybe now we can unmute somebody who want to be involved in some debate, because I want to go through the case not only alone.
All right, sounds good. So who's going to be the brave participant to do this case with us?
So
don't all jump up at once.
I can start also by myself, and later if somebody wants, you can.
Sounds good.
So what are the airway considerations in the trauma patient? Well, this patient does not require airway intervention because he is conscious, as we talk about. But as we can go through our ABC, it is really important to always anticipate a difficult airway in the context of the trauma due to possibility of facial fractures or facial bleeding, as well the fact that the patient will likely be in a C-spine precautions. So the next question would be, does the patient have sufficient vascular access? We have here 2 large bore anti-cubital peripheral intravenous, and in most trauma cases it should be like that. In severe injury patient, it's recommended to have also femoral or central line access. And I would like, if somebody have a clue, or I want to know what you do in your emergency departments, what is the initial choice for fluid administration there?
All right, so does anyone want to chime in? You could also put it in the chat if you don't want to speak up, which is
yes,
fine.
you can put in a chat. What is initial choice for fluid administration in this patient?
What do you guys think? You got options: normal saline, lactated ringers, blood, just
Ringer.
D5W. What do you guys give? Ah, there we go. We're getting some answers.
Yes, saline bolus. That's okay.
Bolus, I think bolus. Yes. There we go.
Yes, usually in my emergency department, we are giving up to 1 or 2 liters of normal saline, ringer lactate, or colloids.
Yep, same. We usually start with normal saline, 2 liters, and then if we don't get that, and sometimes lactated ringers depending. So yes, Dan, you're correct. And then if that is not increasing their blood pressure, we turn to blood as soon as we can, especially if they're losing their volume from blood loss. Okay,
so next I would like to ask, what aspects of this case put this patient at a high risk of deteriorating in the emergency department? If somebody have some clue?
Yeah.
Because we know the first exam was positive. Even his vitals parameters when he came to emergency department came back. I can remind you on how much they would be like in emergency department. They came 110 to 70, and before was 85 to 55. So, but we have first positive. So, yes. So what aspects in this case should the patient put at high risk now?
So guys, what looks really scary in this scenario? Write in the chat. What looks scary? What would you be concerned about? There we go. Head trauma. Good. Yeah, the loss of consciousness. That's a problem.
Yes.
Hypotension. Good. Pneumothorax.
Okay.
These are all things that you should consider. Yep. Low blood pressure. Awesome, I love the interaction. Internal bleeding, hypotension, spleen rupture. So perfect, they think they nailed it on the head.
Well, what I would say that if this patient have positive FACS exam, then that's certainly concerning for a serious intra-abdominal injury. And general teaching regarding the approach to a positive FAST in the setting of trauma would say that if the patient is stable, they go to the CT scanner to localize the injury, and if they're unstable, go directly to operation room. Well, the patient's vitals here appear stable in the emergency department. Some of, I just read days before some observational study that showed that a single hypotensive episode in a polytrauma patient, including pre-hospital blood pressure, predicts a poor outcome. So this is really important not to ignore pre-hospital vitals in trauma patient. Even the trauma patient in the emergency department has a good vitals parameters. Yep. Okay, so let's continue with the case. And as a part of trauma blood work, including blah, 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 a venous blood gas is ordered, which reveals pH of 7.28, bicarbonate 14, base deficit 8. So the question will be, how does the blood gas aid in the management of this trauma? So let's speed up because we don't have so much time.
Yeah.
Well, this blood gas is going with a metabolic acidosis here, as you can see. And this is caused by significant hemorrhage, which leads to tissue hypoperfusion. And as a result, the lactate production is increased and bicarbonate is consumed, causing metabolic acidosis. And the degree of metabolism is quantified by the base deficit. So studies have shown that the greater the base deficit, the higher the risk of mortality in trauma patients. One particular study, which I will finish with this, this study attempt to us, no, it's okay, you can go, So that particular study attempt to identify constellation of factors that predict if the patient needs operative management or you can go with conservative treatment. So next slide, please. So you can see here, systolic blood pressure below 105, positive fast, and if the base deficit is more than 6, then this patient should go to operation room. So if you have some dilemma, if the patient could go to operation room on future investigation for CT scan, you can have these three values in mind. So systolic blood pressure, fast, and base deficit more than 6, then this patient should go to operation room, because sometimes if you make observation of the diagnosis on the CT scan, the patient cannot came to the operation room. So it's up to you guys. Thank you very much. And thank you, Shelly. Thank you for listening. And here is my email. Here is my phone number. If you need some future collaboration or we can speak more about abdominal trauma, feel free to contact me.
Thank you, Nikola. That was an excellent talk, really covered a lot of things, especially that we deal with the emergency.